Pleural. Exudate with a transit. Pleural with pH less than 7.2 suggests empyema and needs just tube drainage. LDH greater than 60% of serum 0.6 or protein greater than 50% of serum 0.5 suggests an exudate. Transudates are caused by infection and cancer. Exudate, transudates. Protein greater than 50% serum, LDH greater than 60% serum, etiology, cancer, infection, connective tissue disease, SLE, rheumatoid arthritis, rheumatosis with meningitis, eosinophilic GPA, pancreatitis, embolism, sarcoidosis, CIC, cancer, infection, connective tissue disease, CIC, cancer, infection, connective tissue disease. Transudate, less than 50% serum, less than 60% serum, LDL, CHF, nephrotoxic syndrome, atelectasis, hypoalbuminemia, CNAH. A 65-year-old woman is admitted to the hospital with CAP, sputum gram stain, shows gram-positive staphylococci, but the sputum culture does not show any specific organism. This X-ray shows lobar infiltrate and not effusion. She is placed on ceftriaxone and azithromycin. Radiosynthesis reveals an elevated LDH and protein with 17,000 WBCs per microliter and pH 7.1. Per culture grow Streptococcus pneumonia with a minimal inhibitory concentration, penicillin less than 0.1 microgram per milliliter, oxygen saturation 96% on room air, blood pressure is 110/70 mm mercury, temperature 38.8% degrees Celsius, and pulse 112 per minute. What is the most appropriate next step in management? Answer is B. Placement of chest tube for suction. Infected pleural effusion or empyema will respond most rapidly to drainage by chest tube or tracheotomy. Stomy, a large effusion acts like an abscess and is hard to sterilize. Each side of the chest can accumulate 2 to 3 layers of fluid. Adding ampicillin to ceftriaxone will have no benefit. A low MIC to penicillin automatically means that the organism is sensitive to ceftriaxone and infects all cephalosporins. The ICU is not required for an effusion or chest tube drainage unless the patient is unstable. Pulmonary consult will not add anything, although it may commonly done in practice. CURB 65 is equal to admission, confusion, uremia, respiratory distress, blood PP low, rate greater than 65. Curve 65 scoring 0 to 1 point home, greater than equal to 2 points admission. Figure 4.7 pleural effusion with a large meniscus sign. Only a fluid sample from radiosynthesis can determine the specific cause. Figure 4.8 effusion should be purely mobile and form a layer when the patient lays on her side. Effusion is mobile fluid forming a layer when lying sideways. Figure 4.9 hypohydropneumothorax is both abnormal air and fluid effusion in the pleural space. Air and fluid in pleural space. Chest tube drainage is the most effective way to remove this condition. Hospital-acquired pneumonia. Hospital-acquired pneumonia or HAP or healthcare-associated pneumonia is pneumonia that occurs after hospitalization in the last 90 days, 1 in 48 hours after admission, and associated with a dialysis or infusion center. Hospital-acquired pneumonia patients have a much higher incidence of gamma-gram-negative bacteria such as E. coli or Pseudomonas as the cause of the infection. HAP differs from CAP in management approach. Unlike CAP, macrolides, azithromycin, or clarithromycin are not acceptable as empiric treatment. HAP treatment centers on therapy for gram-negative bacilli, any pseudomonas, cephalosporins, cefepime or ceftazidime, any pseudomonas, penicillin, piperacillin, tazobactam, carbapenem, imipenem, meropenem, or troripenem. Piperacillin and ticarcillin are always used in combination with beta-lactamase inhibitors such as tazobactam or clavulanic acid. Ventilator-associated pneumonia, mechanical ventilation interferes with normal mucociliary clearance of the respiratory tract such as the ability to cough. Positive pressure is tremendously damaging to the normal ability to clear colonization. Ventilator-associated pneumonia VAP has an incidence as high as 5% per day in the first few days on a ventilator. What is most likely diagnosis? Because of multiple concurrent illnesses such as CHF, even a diagnosis of ventilator-associated pneumonia can be hard to establish. Look for fever and or rising WBCs. You filtrate on chest X-ray, fluid and secretions coming from the endotracheal tube. Diagnosis of a specific etiology is extremely difficult on a ventilator because of colonization of the endotracheal tube. Sputum culture is nearly worthless. The following diagnostic tests are given in order from the least accurate but easiest to the most accurate but most dangerous. Tracheal aspirate suction catheter is placed into the endotracheal tube and aspirates the contents below the trachea when the catheter is past the end of the endotracheal tube. Bronchoalveolar lavage bronchoscope is placed deep into the lung where there are not supposed to be any organism can be contaminated when passing through the nasopharynx. Protected brush specimen tip of the bronchoscope is covered when passed through the nasopharynx, then uncovered only inside the lungs, very specific because of decreased contamination. Metastasis thoracoscopy (VAT) scope is placed through the chest wall, and a sample of the lung is biopsied, allowing a large piece of the lung to be taken without needing to cut the chest open. Thoracotomy is like microscopy of the chest. Open lung biopsy, most accurate test, has much greater morbidity and potential complications due to need for thoracotomy. Culturing an endotracheal tube is like culturing urine with a Foley catheter in place. It will always grow something because of colonization. This portable diffuse subcutaneous emphysema. Figure 4.10 Subcutaneous emphysema is air abdomen leaking into the soft tissue of the chest wall. Chest tube placement may cause air to leak into soft tissues of the chest wall. Treatment is a combination of three drug categories, that is, use one from each category. Anti-subnormal pegidalactam, choose one. Cephalosporin, penicillin, and carbapenem. Second anti-subnormal agent, choose one. Aminoglycoside and fluoroquinolone. Methicillin-resistant antistaphylococcal agent, vancomycin and linezolid. For extended spectrum beta-lactamase (ESBL) producers resistant to at least three classes of anti-subnormal drugs use carbapenem. What if the organism is carbapenem resistant? Use one of these combinations: meropenem vabrobactam, imipenem relibactam, ceftazidime avibactam, or ceftolozane tazobactam. No daptomycin for lungs. Daptomycin is inactivated by surfactant. If specific etiology is identified, change the initial treatment. A man who was admitted for head trauma and subdural hematoma is intubated for hyperventilation and a subsequent craniotomy. Several days after admission, he began to vomit blood and is found to have stress ulcer of the stomach. Lansoprazole is started. VAP develops. Ventilator-associated pneumonia develops, and the patient is placed on aminipinem, linezolid, and gentamicin. Penetrine is started prophylactically. 3 days later, the creatinine rises. The patient then starts having seizures. Repeat set CT shows no changes. What is the most appropriate next step in management? See stop imipenem. Imipenem can cause seizures. Imipenem is excreted to the kidneys. The renal failure has caused a rise in imipenem levels due to toxicity. It is much more likely than a failure of penetrine. Carbamazepine is no more effective than penetrine at stopping seizures. Pneumococcal vaccination recommendations are as follows. Everyone aged greater than 65 should receive vaccination with the 23 polyvalent vaccine. Regardless of age, everyone with chronic heart, liver, kidney, or lung disease, including asthma, should be vaccinated as soon as their underlying disease is apparent. Immunocompromised people should receive both the 13 and 23 polyvalent vaccines. The first vaccination was given age less than 65 or with a condition previously described, give a second dose 5 years after the initial dose. Other reasons to vaccinate are functional or anatomic asthenia, sickle cell disease, hematologic malignancy, leukemia, lymphoma, immunosuppression, diabetes mellitus, alcoholism, corticosteroid use, AIDS or HIV positive, CSF leak, and cochlear implantation. Healthcare workers do not need the pneumococcal vaccine.